growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Steve Rasner here again, continue with the podcast series. Today, I want to talk about what I think is a critical part of the case presentation process, and it's also a part that's kind of awkward to talk about for a lot of us, even myself, and that's getting paid. On the last podcast and of others, and if you see me in person, you know that I'm a big advocate of that either they can afford the care that you're recommending, or there's a reasonable alternative B. That's very important. I'll go back to that. Or they can't. And if they can't, if the recommendation you're going to give is just matching to what their budget allows, and that is your treatment plan, then you're doing an injustice to the patient and to yourself. So that is not something we want. So let's give an example. You know, the patient has an atrophic mandible. They've worn dentures for 20 plus years. The maxilla is not exactly great either. They want a new denture. I think you better be rivetingly clear on their expectations, or don't take the case. That's a case where, 100% of the time, we're very close to it, I'm going to talk about the need for implant dentistry, which is a totally different discussion. Obviously, in one aspect, we're talking, about $3,000 or $4,000. I'm not diminishing, or more, of course, for just regular conventional dentures. For what? For what? What are they going to gain by that on an atrophic mandible? Honestly, and I know that you can maybe justify in your mind by looking at their occlusal wear, and perhaps it is a flat plane occlusion at this point, totally worn, and so new teeth may help. But I think most of us that have been in the front lines for a long time would agree that there's no basis for the denture to be stable. And we all know what the floor of the mouth looks like when that's where the alveolar ridge is at that point, the height of it. And that's doomed for failure. And it is very hard to have that discussion of, even a minimal treatment plan of 3 implants with Zest locators in my office, because that's going to increase things by, $6,000, $8,000, $10,000 or more if we use a bar. And I usually do use a bar. I get it. I hear you. You got to hear me and listen to these. You don't have to do anything, of course, but I'm saying this because I'm so passionate about this aspect, that you don't want to recommend a treatment plan that matches their limited budget. Well, then why not just put 1 implant in? Maybe they can afford $6,000. They can't afford 12, but they can afford 6, so you'll put 1 in. Would you really do that? Of course you wouldn't. And so I think that you need to have in your armamentarium of patient services for them to help them get care would be different patient financing for dental care, which came out in about 1995. And I'll mention all 3 companies that are primary in this arena today and why you need more than just one of them. But before we get to that, let's talk about some other things. The process of getting paid up front is really a process that I've talked about for many, many years. And at the risk of being redundant again, I don't like sending people up in payments that seem like they're going to be able to make them, because when you do that and you get them a little comfortable, often, not even consciously are they doing this, often things in their personal life supersede the importance of your care, and they put you off. And that can turn from weeks to months to even years, until the temporary crown you made them falls off, until they get symptoms under a leaky temporary that now needs a root canal, or even worse, it's going to be lost perhaps. And I am telling you from experience that nobody wins those battles uh, in the community. You lose because they usually tell patients they wasted money with you, and they're not totally forthright about, the circumstances that led to that. I don't know how much nicer I can be about that. So that is one of the main reasons. Not only that, I'll tell you some other reasons I like to get paid up front. I want you to get paid up front because it takes the money out of the picture for the rest of the treatment. What do I mean? I don't know. Go back to the old way of dividing the amount of money that their payments into visits, and now it's a Monday and they're due on Thursday and they owe you $3,500 on that Thursday. And so you have your front desk confirm it on Monday and they say they're going to be there Thursday, and then you do it again Wednesday night. And each time you got to kind of lightly bring up the money, don't you? Because you don't want them to say what they often say. Hey, listen, there's times I've done all this and I still didn't get paid on Thursday. Usually what happens on Thursdays, they don't show. So an incredible tool for diminishing broken appointments on major visits is to be paid up front. Because I haven't met a dentist yet, there may be one out there, that's not going to do good on his end, that you are going to deliver the goods. But there are patients who may not want it to be that way but have to put you off. And it can lead to very bad outcomes on all levels. So I don't see any, I think this is actually ethical, not unethical to get paid up front. And when I say get paid up front, let's just put it out there. I'm talking first day. Treatment plan, if that's the day you gave the treatment plan, that's the day we're getting paid. And it goes back to the first phone call, because you have to have something unique to your whole organization where that fits in. That idea of you getting paid up front fits in. If you're no different than any other office they've called, if they call you and you have an ordinary new patient coordinator that seems borderline disinterested in the conversation, if that's what you have, then all this information I'm giving you is not going to work. You have to have somebody that's a people person on that first call, that can bond with people, that can make a conversation, by the way, because they want to, not because it's manipulative. That's the way they are. I'm not sure. I wouldn't be that person. I'm a person who can get on an airplane and not even say a word to the person to my left or right. Not because I'm mean. It's just because I like my quiet time. It's just not my personality in those situations. So I wouldn't even be good doing that. But the person I have is very good doing it. And they can make conversations and make this person feel, and I hear it all the time. I know what I'm telling you is accurate. And then when they get to your office, that process has to continue. That feeling of Walt Disney clean and warmth when they walk for the first time into your reception room. And that there is a process. They don't sit there in an awkward, untoward number of minutes before somebody gets to them. They can get that anywhere. Now, that's not the reason you get paid up front. I'm just saying, if you're not those things, I think this patient could think of a number of reasons not to want to go through with that kind of protocol. Another part of this is on the phone, if they indicated significant need, then we encourage them strongly to bring their significant other. And I could have a whole podcast on how important that is. And if you really break it down, it certainly isn't rocket science here. We're in 2018. We didn't have implants the way we do today in 1980 or even 1990 in my world. Maybe early 2000s. And that changes the whole scope of the finances, because you can do superior work today. You don't have to extrude teeth to attain a ferrule to put a crown on it anymore. Of course, you can do that. We all know that. But, often you're growing bone and you're doing sinus lifts and you're doing things that can really have an amazing benefit to the alternative for this patient. But at the same time, even in a moderate office of fees can be considerable. So where in the world do we have couples or significant others that travel with each other that make independent decisions of $15,000, $20,000, $25,000. Not very often where I come from. That's why we want them there. So if they indicate, I haven't been to a dentist in 5 years, oh my God, my mouth's a mess. That is a neon sign to your new patient coordinator. Hey, we're going to highly recommend you bring your significant other with you if there's any way possible. And the reason for that is I don't think you've ever met anybody like Dr. Such and Such. And he's going to spend a lot of time with you. And he's going to take his time so that he or she recommends really the right treatment plan for you. And maybe it's one tooth. You could say that. But whatever that is, now this patient just got done telling you, by the way, that they think they have significant needs, or they implied that. So here's the bottom line. I probably get, lately I'm not doing as well as I used to. I probably get 50 to 60%. For a while it was over 70%. Maybe I'm having a bad couple months. I don't know. But you'll get 0% if you don't do it. And I don't know how you would even not want to entertain that. Now let me give you a second one that happened to me this week. Sometimes you'll get a patient that'll say, well, look, I can't be there. Now this situation I'm speaking of was a 47-year-old kid, if you will. And his mother, he implied through the conversations that if he needed help, that his mother may facilitate that. So we were aware of that, and we knew where she would be for about an hour after his appointment time. That is very, very common. And I actually wrote a book called The Protocol Book, What to Do When. I wrote that about 10 years ago. And that protocol is called the Wasted Visit Protocol. Every protocol in that book was a result of something I did wrong for a while and that I corrected, and it improved the situation. So I called it the Wasted Visit Protocol because when I got to the point of presenting the finances of what was required in that case, now we had already spent 45 minutes or an hour with this patient, and God forbid they had pain or a broken tooth, and they had no ability to pay for it. And hasn't that happened to you? Am I the only one in the dental universe that's had patients come in? They don't have a credit card. They don't have a checkbook. They have nothing. Maybe they have insurance. And they're surprised that I'm asking them for a way to pay besides their insurance. I mean, it's amazing to me. I'm even telling you this, but that's the way it is often. So we try to eliminate that from happening, meaning the wasted visit protocol. I didn't end up wasting, an hour with this patient and then not knowing what to do with them. And it can become a really troubling scenario if they have pain. I mean, it's weird. Like, well, you want to say, well, what did you think was going to happen today if you didn't have any money? But obviously you can't be outright impolite. So I avoid all that. In the old days before HIPAA, we would do a credit right over the phone. And I wish those days existed, because guess what? They save the patient a lot of time. Sometimes a patient will be honest enough to say, well, if you're talking about, so we'll say this, let me back up and be specific. Let's say that we say, they'll say to us, well, I just got insurance. So our reply will be, that's fabulous. Not everybody has insurance. But you realize that insurance doesn't pay 100%. And depending on your needs, there could be significant out-of-pocket expense. And we have different plans in the office that will help you with those expenses if you qualify for them. And some people at that point are honest enough to say, not too many, by the way, to say, well, my credit's shot. I mean, that is about, I hear that not 1 out of 10, or 1 out of 100, I'll hear that 2 out of 10, 20%, especially if they're divorced. And look, I don't want to make this cold, hard business. I said that. at the beginning of this podcast, but what I'm telling you is dead on, and I know it is. And what are you going to do in that situation? So we may say at that point on the telephone, well, many of our patients are in that situation, and they have somebody else in their life that sometimes can help them out. And if that's your situation, we'd highly encourage you to consider that when you make this appointment. And that's how this happened. This patient told us his mother may help him out. So let's fast forward. He's in the office. Sure enough, it was a put the fires case out, which means in my case, taking out hopeless teeth. Of course, he needs scaling and root planing. I hate to say it. It's almost routine when so many patients have out of control, poor soft tissue health. In addition to that, I believe there was a number of critical restorations before they became root canals. And you need to know that I am trying on these patients to be ultra conservative. This particular patient actually ended up needing 3 crowns as well. So we ended up talking about a $7,500 treatment plan. So how did that happen? So we go through the whole thing. My new patient coordinator, my financial coordinator, they're the same person, who I'm going to try to have on a later podcast, by the way. You hear me refer to her often. Her name's Michelle, because she's the one that's literally doing the discussions and the verbiage with the patient and the patient's mother and et cetera. But she comes to me in the dead middle of my day. Now, I try to tell her to never schedule these against a surgery, because at least 50% of my day is surgery, extractions, implants, and implant-related procedures. And she does that about 99% of the time. We're good on that. And we were good that day. So she says, I'm about to get his mother on the phone. Can you break for 5 minutes? I swear to you, this is the wasted visit protocol in action. This is what I'm doing. So it's important to me. Treatment case acceptance is how I live. And so, yes, I broke. I could break from what I was doing. Remember something here, folks. I have a heavy percentage of my patients are sedated during treatment. It is a very easy break for me to leave somebody in the room and break for 5 or 10 minutes. Why? Because I give myself way more time on sedated patients than I really need for the visit. So if it's an hour, they're getting 2 hours. I'm not kidding. And they're expected, they know that they'll be there 2 hours. Not because I'm on the phone or I'm reading a book. Because if you're going to treat sedated patients, sometimes you've got to make sure they are stone cold numb and they don't get numb the first time. There's a lot of factors. And you do not ever want to be with a sedated patient and run out of time or feel that you are running out of time. So back to this case, I get on the phone, and I've done this for years. And I try to make it as simple as I can. So I ask Michelle her name, and I say, hi, Mrs. Smith, this is Dr. Rasner. I know this may be a little weird to you that I'm on the phone describing this, but I knew you couldn't be here. And I wanted to give you as much of the visual as I can on what I'm seeing on Jeremy, or whatever the kid's name is. And I said, this is the situation. And I went into it. I said, first of all, and she's a patient of mine, by the way. They're not always, but she was, which makes it easier. So I said, his gums are not in great shape. It's not why he came to me. But I believe you'd be wasting time and money with this if you don't address certain have-tos in his mouth. And I went out to point out that I didn't, my intention is not just to be as conservative as I can be, but he has 2 teeth that absolutely have to have crowns. They are total fillings right now, and I always try to point out the good news. Like with his gum health and his gum treatment, I pointed out that he has, and he did, have substantial bone left. Okay? And I pointed out with the teeth that needed crowns that I was pretty certain that he did not need root canals at this point with these teeth, which a lot of patients think is automatic. And that's important that you know that as good as you can know that, because if he ends up needing a root canal, they're going to not remember you saying you were pretty certain. So if I am less than 60% sure that he doesn't need it, I will say he needs a root canal. And then it'll have to be a decision whether he wants to keep that tooth. Depends what key tooth it would be. Okay, so I'm on the phone for about 4 minutes with her. Then I say, at this point, I'm going to give you back to Michelle, and she can discuss if this works for you or not to help him. And it's your call. My job is to let you know what I'm looking at because you're not here. And that voice is very, oh, by the way, this is what we're doing. It's concern. The voice is important. It's not robotic. It's not stoic. It's caring. It's not salesman whatsoever. And then I give it to Michelle, and she was on the phone for a good 20 to 30 minutes. And in fact, it was an accepted case, and he booked and scheduled, and it was paid for that minute, that day. So how does that happen? Well, listen, I've been lecturing 20 years, and I've been supported by all three of the major companies. So one of them is very new. Care Credit, it's the grandfather. I don't know if they'll like me saying that, of patient financing. They've been around forever. They're a great company. They support dentistry, which I have enormous respect for, meaning they sponsor speakers. They're at every major meeting. They are a big player in the industry. But you need more than one, and I'm going to give you two more, because they use different sources of credit. So the point, all you need to know, is that you can get turned down by Care Credit and be approved by another one. Or you can get turned down by one of the two I'm going to give you and get approved by Care Credit. They all have different terms. Some of them have longer financing availability for patients. I got to tell you, I'm not going to beat around the bush here. It's indispensable in my particular practice model. I couldn't do what I do without it. It just would be impossible. Now, those of you that may be in a big city, in an upper echelon of socioeconomic people, maybe you don't need this. It is a very heavy part of my practice. And it's very important that it's done properly, meaning that they completely understand. I know it sounds ridiculous, that this is a credit card financing for dental care. It is not my office providing that. That is really important. So the other two, most everybody knows about Care Credit. The other two are Lending Club, and the third player that's new in the last year is called Green Sky. And I believe Beth will provide visuals, or she certainly will email you if you might. Dr. Rasner at AOL. I can't think of Beth's email right now. And if you're watching this on YouTube, she'll put the visuals of the companies I just alluded to. You must go out. If you want the kind of practice that I've been describing through these podcasts, then you must take the time and go out next week and contact these companies. Let them bring a rep in. Maybe they'll buy you lunch. I don't care. And have them go over how to use the product. Or you could call my Michelle once you get it in place and ask her more on the verbiage. I want to make some things very, very clear. You may be thinking, I know you're thinking, some of you, what do you mean? You get paid, Dr. Rasner, on the first visit and you haven't even done the work? Have you ever started a case that you were paid for that you didn't finish because you were paid? I mean, I don't even know anybody like that. So of course, why would I not get paid the first visit? Plastic surgeons get paid for the visit, and a lot of the visits I have, the majority of the work is going to be done in a matter of 3 to 4 months, if not all of it, unless it's an implant case that requires bone augmentation, soft tissue augmentation. And those cases are often north of $20,000, $25,000, and they welcome the financing. So one takeaway here today is you need to have more than one company at your disposal. And the three that I use are Care Credit, Lending Club, and Green Sky. So you need to have them on board. More importantly, I can't tell you the number of offices that do have these companies on board and don't know how to use them. They don't know how the timing of it. They don't know how the verbiage to the patient. And that we will elaborate at a later podcast. But for now, I don't do this, obviously. This is done by my financial and new patient coordinator. It's the same person. And I happen to have a good one. And you need a good one. What's a good one? The same person that's your new patient coordinator. A people person. A person that's comfortable. Look, her job, this is what I say when I'm done telling them what I recommend. I said, you're gonna talk to Michelle again. And Michelle's job is to see if she can fit what I've been talking about over the last several minutes in your world. Can she make this work for you? And, I've never had anybody say at that point, what are you talking about? Is this financing? And if they did say that, I would say you're damn right, unless, you can just afford to outright pay for it. Because she's going to come in, and that is going to be an option. I believe she offers a 5% upfront professional courtesy if you pay it upfront. And I may get a handful of people. I don't know what a handful is. Maybe I'll get one I was going to say 50 a year. I don't even think I get 50 a year because that would be one a week. I probably get 20 a year. In my area of the United States, in my socioeconomic demographics, that's what I get. Maybe 20 a year. Sometimes they'll tell you this. This is really important. I'm so glad I'm thinking of these things. Sometimes they'll tell you, well, listen, I'm getting a big settlement, or I'm getting, and that's negative. If you want the case, you have to want the case. And you got to say to those patients, listen, if that's how you want to do it, that's your prerogative. We can get started on this as soon as today, which means you're taking models and photographs. That's what started today is. And you got to elaborate on that. And they know that. Because in my case, they want to be sedated almost all the time for this. So they know they're not getting sedated on the spot. And when you get that check you're expecting, we can just pay it off. And you will have had minimal interest at that point for sure. But often they'll say that. A settlement, my taxes, this or that. You have nothing to lose by offering what I just said. And if you want better verbiage on that, then Beth, maybe you could put up Michelle@pearlsmiles.com and ask her. You could even call her. She's off on Fridays. She'll kill me for this. And you could ask her for exact verbiage, because this is not little stuff, guys. You must take time to perfect it. Do you understand the power this brings you on so many levels? The power of being paid up front for your work. Disregard what I've already told you about. You'll get less broken appointments. That's all true. That you'll have people complete their care. That is true. But the increased cash flow, look, what you and I chose to do is not easy. And on top of that, you don't need to be worried about making payroll in 2 weeks, because you're going to get paid by patients 3 months, 4 months, 5 months, 6 months from now. It changes the dynamics. It allows you to go to your vendors, your labs, your suppliers, and make better deals, because cash flow is no longer a negative factor of your business. So you can go to your labs, you go to your suppliers and say, look, I like to reduce my overhead. And hopefully you can help me participate in that. If I paid you by the 10th of every month, what can you do for me? I'm going to tell you right now. The range that I've received is up to 10% off. From people saying they don't care, that they don't do that, which isn't many. From, I would say, 3% to 10%. I try to keep it real with you folks, and I'm not going to give you numbers that aren't true. But think about it. One of my labs gave me 10% off. I guarantee you I spend about $150,000 a year with that particular lab. Well, that's 10% of $150,000 I didn't have before. That's all mine. And more than that, I said it a minute ago, the pressure without any of this of being a dentist, especially in a comprehensive practice, of maintaining happiness and having your work out and having the crowns always fit when they come back from the lab, and the patient not having pain when you complete the root canal and having the implant integrate and be happily ever after. There is a lot of stuff that you cannot always control in a practice that I'm describing. You got to make a decision. Do you not want any of that? You want the regular crown and bridge practice and not go into all these things I'm alluding to of the blueprint for the practice I have? I'm not the one that made it up that you don't get rewarded for never taking risk. You never can score on a shot you don't take. You need to think about all these things as you alternate and you change and modify the way you've been doing things to have the practice of your dreams. I hope this podcast helps some of you. Please reach out to me, Dr. Rasner at AOL.com, and I'll see you soon.